50 cc's for 10 minutes. And we're going to use a drip set that's 10 drops. So, just do a little bit of division multiplication. Cross that out. So you just get 5 times 10, which gives you what? So you're going to give 50 drops a minute. All there is to it. And so, like, it's instead of sitting there and fiddling around and trying to get exactly 50 drops, what do you think people do? 1 drop a second, because it's easier to remember. Now, you can do the same thing if you use a 100 cc. So again, we just cross it out. 10 times 10 is what? 100 drops a minute. So when you come up with that number, what do you think people do instead of fiddling with trying to just hit 100 drops a minute? 2 drops a second. You're just fine. Those are 2 easy ways to do the amiodarone drip. What I would do is figure out, once y'all are working for your agencies or if you're already employed, go through the protocols, figure out which recipe they use, memorize it, and just use that all the time. Like when I work at, it's always been 150 milligrams of amio in a 50 cc bag with a 10 drop set. That's a drop a second. Just like that. Easy way to remember it.
Okay.
All right, so we'll administer our amio over 10 minutes, and hopefully we'll turn that VTAC back to that. All right, so we're going to travel back in time, just a few minutes ago, and we're just going to change a little detail of the guy at the Walmart Garden Center. You guys are so intuitive. So yeah, you go back to that Walmart on the other side of town you haven't visited today for an unconscious call. This time you find the 56-year-old male slumped on the bench in the garden center. He is unresponsive, he is pulseless, and his vital signs, if you want them, are a heart rate of 140, or a monitored rate of 140, respirations of 0, or BP of 0. So, what do we do next? CPR. We'll say it was on Windows. What I heard the Epi. Epi 1 to 10,000. And so, what makes Epi 1 to 10,000 such a good drug for CPR is that it stimulates the sympathetic nervous system. It's a sympathomimetic. It initiates that fight or flight response over the whole body. And by that, going back to those inotropic, chronotropic, and dromotropic effects that we were talking about earlier, epinephrine increases all 3 of those. So with epi, you're trying to increase your heart rate, you're trying to increase the heart muscle contractility strength, so you're trying to increase that inotropic effect, and you're trying to increase conductivity through that AV node. That's why you're reaching for epi, because you're having all those positive effects on the heart. So in addition to the epi, what else are we going to do for our VTAC that's pulseless? Right, you're going to change up your dose, and you're going to start with a 300 milligram bolus. They do this because they just want the effects to be more immediate. The patient's unconscious, they might as well just go ahead and give them a larger dose, see if they can convert it. That's why they do that. So if you give that as your first dose of amiodarone, can you give any more? Which other bone? 150. 150 milligrams. So what's the rule? No patient can get more than how much amiodarone? 450, that's right. So if you're doing the amio drip, and then they go pulseless, and you give them the 300, are you done?
Yes.
You're done with the amio, pretty much. Unless you want to call for orders and see if the physician wants to do more. Yes?
What if you were in the middle of that rapid infusion and then they code and you push it?
I mean, that's a good question. You're kind of in a gray area. What you would do is, I would just let that drip keep running. So you go ahead and infuse that 150 and go ahead and push that 300.
At the same time.
Yeah.
Okay.
So they're still getting that full total, 450.
Okay.
That's what I would do. Follow your agency's local protocols and whatever they like to do. Yeah, as long as you don't give them more than that 450, you should be good. So, come on, Shane, it's your favorite. Can you pronounce it? Torsades du bois. And hypomagnesia. So just looking at hypomagnesia, what's it mean?
Too much magnesium.
Low magnesium.
Oh.
So going by the principles we did before, a lot of times torsades is caused by low magnesium. What are you going to do? Put some more in, because what's magnesium? An electrolyte. You've got an imbalance of an electrolyte, right? So what do? You try to rebalance the scale. That's why they like magnesium administered for torsades. It's also a smooth muscle relaxer, and it's a stabilizing electrolyte when you're going through the cardiac contractions. Just remember your dose is 2 grams IV. And that's how you treat torsades. Now you can also you can defibrillate torsades, but why is it hard to sync cardioverter? Right. The waveform keeps changing. It's hard for the monitor to be able to sync. That's why you pretty much have to defib torsades if you're going to try to fix it with electricity. Hyperkalemia. Y'all talk much about hyperkalemia this semester? So, hyperkalemia. Hyper means what? Too much. Kalemia is potassium. You got too much potassium. You're going to see this because you're going to have tall peak T waves start to pop up on your EKG. So, you got too much potassium. You see tall peak T waves on the EKG. What's the fix going to be? Sodium bicarb and calcium. Why is that?
Because it messes with your sodium-potassium pump.
Right.
You get too much potassium, and you put some sodium in there, and the calcium is your other electrolyte for the process.
Yeah, because the sodium and the calcium, that's what you're using to balance out the sodium-potassium pump exchange.
So you still got a ton in there, but at least it's in balance.
Right. Or at least you're pushing it, with the idea that you've got an imbalance, you got too much potassium, you're going to increase the sodium and calcium as much as you can to try to rebalance it out.
And then the kidneys just flush out all day. Nice balance there.
Yeah. And mentioning kidneys, that's a lot of times when you'll see this happen is in renal patients, patients with kidney failure who can't who can't clean their blood properly. And so our dose for that is going to be 1 gram of calcium. And then sodium bicarb is going to be 50 milliequivalents. Pretty much the only medication we push that's in milliequivalents is the sodium bicarb. And just to show you how it looks on the monitor, here's the QRS, and here's the T wave for this patient. See how it's taller than the QRS? Yeah, that's a tall PT wave. If you see that, you should be highly suspicious of too much potassium. All right, moving on to another Walmart. This time you're dispatched to the Walmart bathroom. You find a 19-year-old male is unconscious in a toilet stall. I've run this call like 50 times. I don't know if you guys have yet. If not, you will. You find little green pills scattered on the top of the toilet that your partner identifies as fentanyl. What do you expect this patient's cardiac rhythm will be? Bradycardia. Slow. Why? Because it's an opioid, exactly. Opioids are going to generally slow your heart rate down. So, if you've identified an opioid overdose, it's going to slow that heart rate. How are you going to correct that? Narcan. So, what do you expect Narcan will do to that patient's heart rhythm when you give it to them. Yeah, hopefully it'll go up. I'm pretty sure it will. So when would you use pacing versus Narcan on this patient? Yes. Opioid, non-opioid. You're going to want to go ahead and, if you suspect an opioid overdose, you don't want to just slap the pads on and start pacing him, because you probably don't need it. You can just hook up an IV, give him some Narcan, hopefully that'll bring his bradycardia back up to the normal weight. I've seen some students trick before where they come in and the patient's at a heart rate of 40, they go ahead and slap the pads on right away without doing a full assessment, and then they find out 10 minutes later that the patient's got 8 fentanyl patches around the waist like a belt. And so then it's like, okay, we'll push the Narcan, maybe we'll stop the pacing. So, tricyclic antidepressants, you don't see them that much anymore, but sometimes you'll see amitriptyline or something like that. Tricyclic antidepressants, other than keeping people from being depressed, are sodium channel blockers. So what's sodium? If a tricyclic antidepressant is blocking sodium, how do you fix it? Sodium bicarb. If they're trying to keep the heart from getting sodium, you're going to try to give more sodium. Again, y'all start to see a pattern here. How you fix these electrolytes? Yeah, it's all about just keeping them balanced. Tricyclic antidepressants, patients usually got tachycardia, drowsy, dry mouth, nausea, vomiting. I mean, a whole paragraph of symptoms. But it can cause cardiac rhythm disturbances because it's blocking those sodium channels. That throws off the electrolyte balance, throws off the sodium potassium pump exchange. That's why you want to get that sodium bicarb on board if you can identify the tricyclic. There it is. They used to use this in cardiac arrest, but they've kind of taken that away. They found it doesn't really have any benefits from the last AHA out there. And again, always remember sodium bicarb is the one that's in milliequivalents. That's always a popular test question. They'll try to trip you up by putting 50 milligrams. No, remember it's the only one in 50 milliequivalents. So, beta blocker overdoses, like metoprolol, or Betalol. Beta blockers block beta-1 receptors. And the beta-1 receptors are the ones responsible for cardiac output. So if somebody's, if grandma's overdosed on her beta blockers, she's now having a negative effect on her heart. All those inotropic, gonotropic effects are being negatively affected. So what's happening to grandma? Heart rate's dropping. BP's dropping. She died. So now this is one of the quirky ones. What's the fix for beta blocker overdose? Glucagon. By North Carolina State protocols, they recommend giving 2 grams IV. But if you do a little bit more research, some agencies are recommending doses as high as 5 to 10 milligrams IV. But now here's the weird thing: is that they're having a hard time finding the reason why glucagon helps. But they pushed it enough that they believe that it does have some sort of counteractive effect on the beta blockers, and kind of cancels them out. Yeah. But again, if you go try to find research to back it up, it's hard to find. They don't know why, but they have you do it anyways. So just keep that in mind for beta blocker overdose. Try some glucagon. All right, so let's go over just a quick review and see if we can figure out some of these things. So, of the medications we've gone over today, which ones are sympathomimetics that help the sympathetic nervous system? Epinephrine. And one we hadn't mentioned today, but I thought I'd throw in there, is albuterol. So when you give a patient, when they're on their 4th NEB treatment, their heart rate's probably, It won't be through the roof, but probably be tachycardic. That's because albuterol is a sympathomimetic, just like it has some of the same effects as epinephrine. It's a beta agonist, and so just like we're talking about the beta blockers blocking the beta 1. Albuterol is it's having the positive effects on those a little bit on the heart, because it's also a beta agonist. So from what we talked about today, do you remember what was the anticholinergic? Atropine, exactly. Now, kind of related to atropine is the ipratropium bromide, otherwise known as what? Atropine. When do you give atropine? Respiratory failure. So another reason why, if you put the patient on their third neb and you've given them their second round of ipratropium, what's their heart rate going to do? Going to go up. Exactly. So, I remember, my mind was blown one time when I was with my preceptor, and he's like, so what's ipratropium bromide? I was like, I don't know, it's like respiratory drug. He's like, it's related to atropine. It's right there in the name. Antiarrhythmics. What did we cover that was an antiarrhythmic? Venocin, Cardizem, calcium channel blockers, amiodarone, and sulfate can be an antiarrhythmic. There you go. All right. Everything we talked about, what are the electrolytes? Sodium, calcium, mag sulfate, and potassium. We don't give potassium, but it's one thing. So, just to sum up. Know the cardiac effects of the drugs you push, especially the desired effects. Like for instance with the atropine, just know that if you don't administer it fast enough or in the proper amount, you can have the opposite effect of what you do. Also think about some of the effects of medications that you're given that you might not typically think are heart medications, but they have heart effects anyways. Like when you give the albuterol and the adjuvant neb, you're going to jack up that patient's heart rate a little bit. Recognize the connection between the patient's heart rhythm and the medications that they might take. So, just like we're talking about some of those overdose scenarios, if you find that grandma's on beta blockers, you probably want to start looking through that pill caddy, see how many she takes, and see if that gives you a clue as to why she's being bradycardic, as opposed to just some sort of random cardiac event. So start trying to use some context clues provided by the medications that the patient takes. And then, of course, use electrolytes whenever you find that electrolyte imbalance. Like with the calcium channel blocker overdose, or with the tricyclic overdose, or if the patient's got too much potassium with their hyper-K. When you find one electrolyte's, you got too much of one or too little, try to balance it out with its opposite. So that's what I hope you take with you from today, the rest of the semester. All right, folks, I appreciate your attention, and hope you all have a good rest of the day.